All right, hey there, Brandon again with Revital Health Clinics. This is video number 2 around the topic of testosterone replacement therapy in men. This video is titled "To Treat or Not to Treat." And as you can probably guess by the title, it's a discussion around whether or not one should start testosterone therapy. And it's going to be kind of a review of things to consider from the clinician side. A lot of risks versus benefits that is or should be weighed out every time you're thinking about a treatment plan. So I want it to be helpful to the clinicians who may be watching, and also helpful to patients, hopefully, or persons that are just trying to get a little more info on the topic. All right, so one of the first things to think about is, are you dealing with insurance? If you're dealing with insurance, then you must meet the requirements given by that payer for medical necessity. In this case, medical necessity for treatment of hypogonadism or low testosterone. They will have a certain level below which the testosterone total testosterone will need to be. In some cases, they will accept a free testosterone. In others, they may not. Believe some of the federal payers will not accept a free testosterone, which is insane. But that they're the ones that make the rules. So, do you meet that payer's requirements for treatment? That's the first thing to consider. If they're not using insurance, then again, you've got a lot more wiggle room, and you can treat as you see best. All right, so let's say you're using insurance and you've checked off the requirements that payer has for medical necessity, or you've got a self-pay patient. Either way, you've got what you need to pursue this further, and you're thinking about starting testosterone therapy. One of the first things you might think about, and this is also involved in part of the diagnosis workup, I guess. Is there something that's suppressing his levels? The medication. 2 medications that are prominently known to lower testosterone levels. One is opioid pain meds. Any kind of opioid taken long term, and by that we mean more than a week or 2, and typically we're thinking of months, taken daily for months at a time, or for months plus. So one is he taking a medication like a pain med, an opioid pain med, not Tylenol or ibuprofen, and if he is, can he stop it, or is this something that he's unlikely to stop? The other one is corticosteroid meds. So a common one might be prednisone. Maybe he's got a condition where he takes prednisone regularly, daily. Those 2 meds we know can suppress your HPG, hypothalamic pituitary gonadal axis. It can suppress that axis, and because of that, testosterone levels can become very low. So is he taking something that's causing it to be low, like one of those 2 medications? Next thing you might think about is, and this is all, we're weighing out risks and benefits about starting therapy. Is he obese or heavy, in the sense of overweight or obese, a high body fat content? Fat will lower testosterone levels. secondary to estrogen. The more fat a guy has, the more estrogen he will tend to have. More of his testosterone is going to be converting into estrogen. The enzyme that does that, aromatase, is found it's more concentrated. It's found more in fat cells. So the more fat, typically the more conversion you have, the higher the estrogen, and estrogen will suppress LH, which is the pituitary hormone that tells the testicles to make testosterone. Okay, so is he overweight or obese? Weight loss, we know, can increase testosterone levels. Now, do you go down that path? You could. You could suggest, and you definitely should inform the person that significant weight loss can definitely increase levels. Although, in my opinion, it's not going to. It typically is not going to be a game changer, in the sense that if he's low and he loses a significant amount of fat, yes, his levels could return to normal, and he may feel better, and I would consider that a win. I think it's unlikely that losing a significant amount of fat will take his levels to optimal, which is what we tend to strive for here at this clinic, because there's a lot more benefit to health and certainly how you feel when you have optimal levels as opposed to just average or normal. But this is where I believe that we have to have this dialogue with the person, and let them know that if you're able to lose a lot of fat, your levels could be normal. There's plenty of studies that show that. The most recent one I saw, often they're looking at morbidly obese gastric bypass patients. Those patients will lose 50, 60, 70, 80 plus pounds, and their testosterone levels will go from deficient / low back up to completely normal. And by normal, I mean in the 600s, which to go from 100s, 200s to around there is a win. And so that needs to be mentioned. Men at that point, when they're already in that body habitus, their metabolism often is such where it's difficult. It's not impossible. I'm not suggesting that, but it is difficult to. And I'm more referring to starting to work out with weights or any body weight, any kind of resistance. Initially, there's a hurdle they're going to have to get over, maybe a few, because their testosterone levels are low, so it's not going to be as easy for them to put on muscle and recover due to the low testosterone levels they have. And full disclosure, it's no secret, and I don't mind saying I'm definitely pro TRT. I'm a pretty big proponent of testosterone therapy, specifically testosterone optimization, in the sense that if you're going to replace the hormone, let's replace it back to an optimal level, and that could be a conversation in of itself. But I am pro TRT, and in many circumstances, I will lean towards replacement therapy. That does not mean that's what will happen 100% of the time. There is definitely a dance, if you will. It's a discussion, a dialogue between the clinician and the patient about what's best for them. And for me, if I find out that another route is what's best, then that's the route you have to take. But in general, my inclination is often to consider replacement therapy. There are a few caveats to that, and we can definitely get into that. So we've talked about a medication that may be causing it. Definitely think about that. If they can stop the medication, it's worth trying and seeing if the levels were turned to a good spot. Hopefully middle of normal range or higher. And if their symptoms resolve, those two things. And then, do they have a lot of weight to lose? Some guys will opt for really buckling down with, a diet and exercise program and try to get that weight off and see if they can do it naturally. And as far as I'm concerned, if you can keep good hormone levels naturally, that's a win. And maybe once you get to an age where you're no longer making optimal or healthy hormone levels, then maybe that's when you consider replacement therapy. But until that point, if you don't have to take a medication and just let your body do it naturally, great, perfect. Problem, if you consider it a problem, is eventually we're all gonna have levels that are subpar and or low. Testosterone, as some of you probably already know, it lowers on average about 1% a year, starting around age 30. Some people say 40. I think it's probably definitely around 30 nowadays. As unhealthy as we've become as a nation, probably as a world, certainly first world countries, industrialized nations. There's probably a lot of reasons for that. Food for sure, stress for sure. So if you can do it naturally, great. But many of us will get to a point where we're no longer producing levels that are optimal or healthy. And in that state, that's when hopefully you talk with someone and you make that consideration about replacement therapy. But with anything, and this is what we're talking about, treat or not to treat, there are risks, and that you need to weigh that out. When the benefits vastly outweigh the risks, then that looks like a good idea. Everybody's different though. Some people, you tell them that their testicles may shrink. That's game over. That doesn't tend to happen, but everybody weighs risks differently. Some people, just the possibility of losing hair, some hair on the top of their head, it's game over. Shut it down. They're not even going to consider it. Again, everybody weighs out the risks differently. All right, so we're weighing out risks versus benefits of TRT. We've talked about a few of the potential risks already, but we're gonna weigh some more out. So often, in my opinion at least, the benefits often will outweigh the risks, and some of those risks are going to need maybe a little more detail than we're going to give it in this video. We may have to do some other ones that are specific to some of those perceived risks. But the benefits are essentially the opposite of some of the signs and symptoms of low testosterone. Things like regrowth of hair on the face, body, everywhere but the top of the head. Which, man, if that was the case, then we wouldn't be able to keep this stuff on the shelves, I guess. Interesting factoid about hair follicles: depending upon where they're at on the body, they tend to react differently to testosterone. follicles on the top of the head, the scalp, do not act the same way as hair follicles on the face and the body. So you tend to see increase in hair growth in some guys on their face and body, and no change on the top of their head. Now, I've had some men who have said they felt like their hair was growing more on their head. Maybe that's possible. I haven't seen any evidence to support that. And by evidence, I mean like studies or articles showing that. On the flip side, there is a risk for hair loss on the top of the head. It is not a common side effect, I guess you would say. But if a guy has a genetic predisposition to higher DHT levels, causing miniaturization of the hair follicle or thinning of the hair, male pattern baldness, if he has a genetic predisposition to that, then that is something that you could see. So it is a potential risk of accelerating hair loss. Although it's good to kind of keep that into perspective with it should be no different than what you would see if the guy naturally had really good testosterone levels. And so the joke sometimes is, it's maybe not very funny, maybe, is the guy will often have to make a decision between hair and erections in regards to testosterone therapy. Good news is that is not typically the case. Again, it appears to be only in men who have that genetic predisposition for higher DHT levels, causing thinning of the hair. And for those of you who don't know, DHT is a metabolite, a downstream product of testosterone. The way I look at DHT is it is testosterone's bigger, stronger brother. It's testosterone, times 10. It's a lot. It has the same effects on the. It acts on the androgen receptors, but it's a lot stronger, has a lot higher affinity, wants to hang on longer than testosterone. Testosterone can go in one of two directions. It can go either into estrogen or estradiol, or into DHT. And that's maybe a topic we can get into another time. So hair growth on the body and the face is a potential benefit. The flip side is that there could be a risk for hair loss, although that is not something that we see a lot of. It's rare to see, and it certainly isn't as if the guy starts testosterone and then a week or two later his hair is falling out. If it happens, it tends to be subtle, and there are some things that could be done to maybe help prevent that if the guy didn't want to stop testosterone. And that also another discussion, another video possibly. So benefits, we mentioned that one. Erections will sometimes improve. That is, in my experience, about a coin toss. About half the time there's a significant improvement in erections. Strength and longevity, how long the erections will last. So getting and maintaining an erection, a good erection, about half the time there's a significant improvement. The other half of the time there's not a big change. Okay, in those cases, if the guy's already on testosterone therapy, maybe you add something else in to try to help with that, and that's perfectly acceptable, and it happens all the time, and that can help. Morning erections, you may see more of those. Sex drive, so this is something separate than erection function. This is your libido, your interest in sex. That almost always goes up. If a guy is deficient and you replace his levels back up to normal, ideally optimal, going from low to optimal, there is almost always an increase in sex drive. and that could be a good thing, a benefit, and in some cases it can cause problems with the significant other. And there can be some headbutting that happens sometimes when the spouse or the significant other is used to your sex drive at here, and then a few weeks later, a few months later, it is very much a lot higher. And so sometimes there needs to be some compromising going on, or an adjustment period. So that's one good thing that could be a good thing. Now, if the spouse has been complaining of a low sex drive, or her sex drive is quite a bit higher than yours, then that can be a beautiful thing. That the guy's sex drive goes up quite a bit. It could be great. Other benefits that you can see with TRT, and these are less specific. I don't know if that's the right word, but the evidence is not as great for these. And when you say that, you got to take into account that a lot of the studies done on TRT, they're not great in the sense that the levels being given, the dose that's given is not a good dose. It's often, in our opinion, dosed very weakly. And if you want to show no effect with a medication, or little effect, just don't give enough of it. That, in my opinion, seems to be the biggest problem that you find with guys that are already on testosterone therapy. They're just not getting enough of it. 500-600 nanograms per deciliter on their total testosterone is just not going to do it for most guys. Some will have that 180. They feel a lot better, and that's better than nothing. Certainly, 600 is better than 200. All right, for overall health, agreed. But many are not going to get the full benefit until you push them towards that 1,000 mark. Other benefits you can see with TRT, some of those things that I said there may not be great evidence for, or an abundance of evidence for, are things like energy. Fatigue can resolve or improve drastically. Certainly mood, which often tags along or goes along with energy level. Which comes first? I don't know, you tell me. Chicken or the egg type thing. But mood will often improve. Depressive symptoms can improve. I'm not suggesting that testosterone therapy is the go-to for a major clinical depression. I would say that it should be considered in anyone with depressive symptoms, maybe as an adjunct, but I haven't seen a lot of evidence to suggest that it's effective for major depressive symptoms. But for that dysthymia is what it's called sometimes, not a depression, but a recession, if you will, kind of a low mood, blah, kind of a blah mood, humdrum. Testosterone can help. So it can help with mood, help with energy, body composition. It's no secret why professional athletes and bodybuilders abuse, if you will, or take testosterone, and typically in very high doses, because it will allow you to gain muscle faster, become stronger. It's an anabolic steroid, right? Anabolic means to grow or to make something. So it does tend to increase muscle mass and strength as a byproduct of that increase in muscle. So the health piece that comes with that on my side of things, or the wellness clinical side, that's a huge boon to health. having less fat and a good lean muscle composition is a huge benefit to overall health. Um, when you start seeing a lot of chronic health conditions, it's no wonder that the person is often overweight or obese. They've got a lot of extra fat laying around. Fat is very much a part of diabetes, heart disease. You name the chronic health condition, there's an association there, almost always. So that's a huge boon to health, maintaining that healthy, lean body composition. Part of that, kind of diverging a little bit, that the more muscle, the higher your metabolism. You're going to burn more calories just sitting still when you've got more muscle. So that's a help to the metabolism, helping keep the fat and muscle in a good, healthy proportion. Huge. Can't say enough about the benefit to that. So we've kind of went over a few of the benefits, and then there's the risk side. You need to weigh out the risks. When we're thinking of risks, let's go ahead and talk about the big ones first, the so-called major contraindications to testosterone replacement therapy. There are other ways to increase testosterone levels other than giving someone testosterone, and that's something we can have another discussion about, a video, a post about. But talking about testosterone replacement therapy, one of the first things to ask or look for, and when you're going over the history of a person or thinking about starting therapy, do they have a history of prostate cancer? In general, if they have a history of prostate cancer, you really want to think about not treating them yourself and referring to a urologist who is comfortable, hopefully, considering treatment in certain circumstances. Many moons ago, and unfortunately still some clinicians, doctors, mid-levels still will tell patients that testosterone fuels prostate cancer or increases your risk for prostate cancer. No, 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 and no, it does not. That's been laid to rest. Dr. Morgenthaler has dived into that very deeply. He's got a great book that is, I think, a must-read for clinicians and patients alike. It's called Testosterone for Life. Actually, I have it here. There you go. There's let's try not to spend too much time on this, but the evidence that thought idea comes from is based upon a very weak study with, I believe, one patient, and the background on that is very interesting. It was a guy, I believe, named Higgins or Huggins, and some other people, and that's that one study is what has led to the past however long, 30, 40, 50 years, how long it's been since the study was done. But in general, if the person has an active prostate cancer, certainly, or you're concerned about prostate cancer, them having it, maybe their PSA comes back, pretty elevated, and you, again, diverging a little bit, but you don't think they have some kind of prostatitis or some other reason. You definitely be careful, and in those scenarios, send them to urology, and let them take over. There are more and more urologists now that treat men with prostate cancer with testosterone, and they do just fine. I am not a urologist, so the ins and outs of their thought process, I don't want to assume to know, but if the guy has prostate cancer, or you suspect prostate cancer, or a history of prostate cancer, definitely punt to urology, or if you've got a good relationship with one, consult with them. If the prostate cancer was 5-10 years ago, and it's been if the prostate's been removed and the PSA is undetectable, there may be some other scenarios where if the prostate was not removed but it was treated, then treatment I think is something to definitely be considered. But consult with urology. So they don't have. Let's assume the person does not have prostate cancer. Breast cancer is another one that's mentioned. There's not great evidence for why a man with breast cancer could not take testosterone. And I guess great's a subjective word, right? My great may mean something different than your great, but the general consensus is if a guy has breast cancer or a history of breast cancer, you do not treat him with testosterone. Again, I don't think the evidence is great to support that, but in general, maybe pump that to someone who's a little more knowledgeable or comfortable with how to navigate that issue. And we can again maybe do another more in-depth video on my thoughts on that, and things to look for and how to go about that. So major contraindications: prostate cancer, breast cancer. In general, do not treat. If they have severe untreated congestive heart failure, which hopefully is very unlikely, but if you happen to catch that guy that hasn't been to the doctor in 10-15 years and he has no family or loved ones that I guess ever see him or check on him to say, hey, you look horrible, you can't breathe, we need to get you to XYZ, you don't treat that guy. Testosterone therapy, especially the injections, but any therapy with testosterone could increase fluid, could cause some fluid retention, and that would be not a good thing for a untreated or very poorly treated severe congestive heart failure. Those are, and I guess that's one of the risks of therapy is some fluid retention. We'll come back to that maybe. So don't treat. We talked about major contraindications: prostate cancer, breast cancer, untreated or poorly treated, severe CHF. All right, so other less major concerns are still very important to consider when thinking about starting testosterone therapy. One that's very important is fertility. If you give a guy testosterone and don't give him anything else, his sperm counts are going to drop considerably and will very, very, very likely become low enough where he will be infertile. And that can generally, I would say that within a few weeks to a few months, but that how quick he'll become infertile. So the guy that's thinking about having children in the near future, testosterone is not a great first-line recommendation by itself. Right? There are some things that can be done to try to help support fertility, but if we're just talking about only giving him testosterone and not something else with it, like HCG, maybe Clomid, although in my experience Clomid does not work well in conjunction with testosterone to try to help support fertility. I like HCG with it, but if you're not thinking about that, and he is planning on having children in the next few months or the next 6 months, or then whatever the near future means to you, I guess I think 3 to 6 months is maybe a fair consensus. We can take a vote another time. then testosterone therapy is not a good idea, because he will be infertile, very, very likely will be infertile, and will be unable to have a child of his own. So that's one risk that needs to be talked about. It can be a little counterintuitive to some men or some people new to this, that testosterone would cause a decrease in fertility. Initially you might think, well, I would think it would help fertility. Well, testosterone is very important for some of the cells in the testicles, the Sertoli cells. It's helpful for those cells to be around high concentrations of testosterone, and that helps support sperm production. What happens when you give someone testosterone in some form or fashion, whether it's topical, injected, I guess they have nasal sprays now, which I've heard are not that great, but don't know for sure. Haven't really looked into it a lot. When you give someone testosterone, their own production of testosterone will very soon stop. The brain, the pituitary mainly, hypothalamus, but pituitary mainly, will sense good levels of hormones, and it's mainly sensing estrogen, which is essentially the same as far as the body's concerned. Testosterone and estrogen often they run together. Okay, they're boys. Testosterone will convert into estrogen. It's meant to happen. The body is built that way. So the pituitary is more so sensing estradiol levels, but for ease of conveying a message, sometimes you may hear people say testosterone, or they may not know, but it does sense some testosterone levels from my understanding. But so the brain, the pituitary, will sense good hormone levels, good testosterone levels, and it will stop sending signals down to the testicles to make testosterone, because it thinks everything is good. We don't need to tell the testicles to do anything. Those signals come by way of pituitary hormones LH and FSH. LH is the main hormone that tells the testicles to make testosterone. The cells that do that are called Leydig cells. They respond to LH. When you give someone testosterone and those signals become non-existent, even though in the serum, in the blood, in the body, if they're being treated optimally, the levels are very, very good, the testosterone concentration within the testicle is not good. It's not the same as what's around in the blood. So that's why you see infertility with testosterone therapy. You need a high concentration of testosterone within the testicle in order to help support that fertility, that sperm production. So fertility is one of the first things that you really talk about with a guy, especially a younger guy with no kids. If he's, early 30s or less, with no kids, you need to make it very clear, and I have him normally sign or initial that we spoke about that. So that's one risk there. Is he wanting kids in the near future? We say near future. The updated guidelines, Endocrine Society guidelines, which is typically what most everyone, and I guess it makes sense. Many people will base their protocols around the Endocrine Society guidelines because they are the so-called experts, and I don't mean that in a negative light, even though it kind of comes off that way. But the newer guideline, I believe, if I have to go back and look at the 2010 update, but the 2018 update, I believe, adds in the phrase wanting children in the near future. whereas the older ones said kind of wanting children at all. And I think that's helpful and important to note. The vast majority of men, if let's say the guy's not wanting children right now, but he's wanting it in maybe a few years. It's not even on his radar right now. He's not even with someone that he's seriously thinking about having children with, or with anybody at all. If the person stops testosterone therapy, and it depends upon what mode of therapy they're using. If they're using an injection like cypionate, the half-life is longer, so it's going to take a little bit longer for them to reboot. But the vast majority of men, once they stop therapy, within a month to 3 months, their fertility, their baseline levels and baseline fertility, whatever they were before they started therapy, is going to return. That's the vast majority of guys. Let them reboot. It takes a little time for the pituitary to start talking to the testicles again, but assuming, and that's why I say baseline, assuming they were X percent, that even doesn't make much sense, but assuming they were fertile pre-therapy, if they stop therapy, their fertility should return within a few months. We have to let them know, though, there's always, and I guess, anything's possible, but it's kind of a CYA thing, even though it's, the evidence for this is I don't know, I hate to say not there. I'm sure maybe somebody can find something. But the evidence that this is a real issue is severely lacking. You always say, we tell the person there is the possibility, although very rare, that if you start testosterone therapy and stop, your fertility may never return. Some will get freaked out by that. Most, I think, know that it's kind of a CYA move. We have to kind of mention that, and it is possible. I have never seen someone who that's happened to. Now, in fairness, do I follow up with every single patient I've ever seen and started on testosterone therapy? No, no one does. But I do see quite a few who stop therapy, come back later. Many times they've stopped because they wanted to have a child. They were successful in having that child, and they come back to start therapy. But you tell the guy that there's a very rare possibility, but it's possible that your fertility may not return at all, or you may have to go through treatments to try to regain fertility. But know that that's a very rare possibility. So you talk to them about that. That is a risk to note. And then now we start getting into what I would call more mild, less big deal risks. Again, I think I've mentioned previously the evidence for cardiovascular disease, heart attacks, strokes with testosterone therapy is very weak. Maybe 2013, 14, there were a few studies that came out, 2 or 3, all within about a year of each other, that supposedly showed an increased risk. Many of those were very poor, very weak. I think one had to actually go back and retract some of the statements or make amendments to some of the things that they had stated. Some of the statistical methodology used in one was very odd and weird, even to the relative layperson who read the study. They could see that things didn't add up with the statistics they were showing. But there's still that concern in some people's eyes. All I would say in a quick way about it is the evidence for that's very weak. The vast majority of evidence, so there's 2 or 3 studies or over here or whatever, 4 or 5, and then you got like 100 over here. Which outweighs which? But the vast majority of studies show a health benefit, including a cardiovascular health benefit, to replacement of testosterone. specifically compared to leaving it low. And there's a lot of good evidence that shows that is a health risk. And your risk for cardiovascular disease, strokes, heart attacks is increased with keeping a low testosterone level, likely due to a lot of the things we've already mentioned. So you talk to the guy about the concern for cardiovascular disease risk. I hate to say that that's a mild one, but because it's really non-existent, and it's in my opinion, the evidence is pretty clear at this point. I don't consider it to be something to really spend a lot of time on if you don't need to, in a major risk. Increase in red blood cell counts. Testosterone can increase production of red blood cells, and this is something I definitely want to have another video on. I think this is a very interesting topic, but there is a concern about increased risk for clots due to a elevated red blood cell count. Okay, the thought goes like this: that if the red blood cell counts become too high, the blood is then more thick or viscous, and because of that can be an increased risk for clots. The evidence for that is not good, in fact weak, and definitely have another video about that, but that is something to consider, or at least inform them that a potential risk is I guess the way I would word it. Again, very weak evidence for that, and we can definitely get into that another time. The majority of the evidence you find for that thought path is based upon another condition called polycythemia vera, which is not the same as what we're talking about here. What we're talking about with testosterone therapy is erythrocytosis, and I know it's kind of semantics, but the point is important. Erythrocytosis is high red blood cells, or an elevated red blood cell count. Okay, polycythemia vera is essentially a blood cancer where red blood cells and white blood cells and platelets, often all three of those are elevated. And high platelets, we definitely know that can increase risk for clots. So a lot of the concern is extrapolated from another health condition which is not the same. And I'm sure we can have a very healthy discussion / argument, depending upon who we're talking with, about that, and I'm happy to do that, and I'm open to that. In fact, very interested in that topic. But that is a potential risk that needs to be noted. The potential for that. Typically, you see it with the injections and with older men. And by older, I mean above 50, 55. But you can see it younger too. But often with the injections, that's likely due to the peak that you get with the injections. You get a peak and a trough with cypionate or enanthate. Half-life's about 7 days, so about a day or two. I say a day. About a day after the injection, you're going to have your peak, and that's often super physiological. So it's that peak that is thought to really rev up that bone marrow and cause it to produce more red cells. The mechanism for that is maybe also another discussion. You kind of find mixed stuff. It's EPO. It's due to an erythropoietin, an increase in EPO. It's not necessarily due to EPO. It's other hematopoietic growth factors, and we can get into that. That's kind of a detailed discussion maybe for some of the clinicians. to munch around on another time. But something, it's a risk to know. Increased red cell counts, if they do go up high, and again, we really do gotta have a video on this. The common method of dealing with that, if they go high, if they get elevated, and high depends upon, I guess, your definition, but let's just, for this video, say that high is anything above the reference range for the lab you're using. Often for the hematocrit, it's 51% often. But whatever that reference range is, high, for the purposes of this video, we're going to consider that above the reference range, above the upper end of normal for that lab. The common fix, resolution, is you either stop therapy, lower the dose considerably, or get a blood donation. So have the person, hopefully they can go to the Red Cross and donate. Some may not be able to donate, and you'll need to either do it in the office or send them somewhere for a therapeutic phlebotomy. But those typically are the three methods that you'll find when someone's counts go high. And I'm sure this is going to need more time, I'm not too worried about a slightly elevated red cell count in the vast majority of guys. Certainly if the guy's fairly healthy, non-smoker, if it's 51, 52, I mean, kind of who cares? The caveat to that for me is if he's symptomatic. There seems to be a subset of guys that at least report they don't feel as good, kind of sluggish, and maybe a headache when their counts are high. Really interesting. But in general, those are the things you can do when you see or that you're recommended, that you're often going to be recommended to do when you see a elevated red cell count. And hopefully I'll follow up with a video very soon about my thought process and the way I like to look at those things. So we mentioned the hair loss, the higher red cell counts, prostate gland. We talked about potential prostate cancer concerns. I more so phrase that in the sense of testosterone does not give you prostate cancer. It does not increase your risk for prostate cancer. Although if you had a prostate cancer currently, or you were to get prostate cancer later in life and you're on testosterone therapy, that could help it live a little easier, possibly make it worse. What's interesting with some of the studies done on prostate cancer and testosterone, and this is all Abraham Morgentaler here, who's a Harvard doc. There appears to be a saturation effect with testosterone and prostate cancer. So if you shut down testosterone to 0 and then you give someone some testosterone, you can see that prostate cancer that it shrunk after you've put the androgen levels to 0, and you give them testosterone, you can see that shrunken prostate cancer starting to grow some. But up to a certain point, I guess my main point was that above a certain level of testosterone, you don't see any further growth, at least in some scenarios. And I'd have to refresh myself on some of those articles and studies he's put out. He's prolific. I mean, that guy puts out a lot of work. Shout out to Dr. Morgentaler. So I mentioned that as a risk when I talk to patients, that if you had prostate cancer and we're not aware of it, and of course you'll do a PSA test to try to screen for that. Maybe I shouldn't say of course. Many of us will do a PSA test. That's something also different in the updated guidelines for Endocrine Society on TRT in men. Some of the wording about recommendations of screening for prostate cancer have changed, and I think that's a good thing as far as that piece of it. We can come back to that. So you mentioned about if you had prostate cancer or you were to have it later in your own testosterone therapy, it could help it live a little easier, possibly make it worse. And so that's why we're going to be giving you the option for us to follow or to screen you as we go. That's historically been what has been done. That may start to change now with some of these recommendations. We'll circle back on that one. Prostate size, growth, BPH, the prostate gland getting bigger. There's not great evidence for that either, although that is listed as something that needs to be a concern. And towards the end here, breast enlargement, everybody's favorite, and often for the guy that likes to read up on the internet, which is almost everybody now, if they do a little extra reading, or maybe they have been or know someone but have been involved with working out or exercising, maybe they've come across the term or heard somebody use the term of breast growth. The medical term for that risk is called gynecomastia. That is glandular breast growth that can be seen with almost always it's poorly managed TRT, and many times it's the person's not under the care of a medical provider. They're doing it themselves. But there is that risk there, and it appears to be due to higher estrogen levels, and probably more importantly, a ratio that's out of balance, the androgen to estrogen ratio. So the breeding ground for gynecomastia is a higher estrogen level and a lower testosterone level over a long period of time, not a few weeks. So the breeding ground for gynecomastia is a lower testosterone level and a higher estrogen level over a long period of time, not a few weeks. We're talking, 6 months plus. That is not absolute, okay? Because there are guys that have very high testosterone levels and estrogen due to the testosterone that do develop gynecomastia, often in the setting of bodybuilding or guys that are working out in the gym. So there likely is a threshold when the estrogen gets high enough, even when you've got good testosterone levels to go along with it. For the guy that has a predisposition for that, it's gonna take place. I mention that because I think for the vast majority of patients, when they're under the care of a clinic like ours or someone else's that knows what they're doing, replacement therapy or optimization therapy of testosterone, the only times you're going to have a scenario where you maybe need to be worried about that is for the guy that has a sensitivity to estrogen. If for whatever reason his breast tissue, the receptors are very sensitive to estrogen. That's my first thought, and so he'll alert you. Hopefully, sometimes people get a little too worried or finicky, and that's another conversation we can have about importance of estrogen and try not to lower it unnecessarily. But the gynecomastia comes with a calling card, and that's the breast tenderness, nipple sensitivity, all that stuff comes long before you ever get growth of glandular tissue, and that's also important to mention real quick. Breasts are don't necessarily, and I'm talking about a man with some breasts. That's not really the correct term in the sense of like a female breast. Females have a lot of glandular tissue. Men don't have anywhere near as much. But we can put fat in there. So Pseudogynecomastia is fat, it's adipose tissue. That is not true gynecomastia. True gynecomastia is glandular tissue. Typically it feels like a rubbery mound, and it's normally sitting behind the nipple. And you can easily feel the difference. And when in doubt, you can always get some imaging done to help you. But that is a risk that needs to be mentioned, although very rare to have any real concern about that. The good clinician is gonna have that addressed long before it ever reaches the point where you're actually getting some gynecomastia. You will have already addressed it in some form or fashion. If you come across a guy, as a side note, that's already developed it, typically what you read is beyond a year that the gyno is going to be not very amenable to treatment with medications. Before that mark, you can reverse it often with medications like tamoxifen, things that block the estrogen receptors at the breast. But after that point, often the tissue is become fibrotic, or it's going to need to be resected surgically. It's going to need a surgeon's touch, if you will. So something to mention, I guess, typically we'll have a list of things that we mention, potential risks of therapy. But again, all of these that I've mentioned are, for the most part, mild, easily managed, and the ones that are maybe not so mild, I'm thinking of like the mild ones. I'm thinking of oily skin, some nipple tenderness, and again, often going back a little bit, it's not uncommon for a guy to get a little breast nipple tenderness. Normally it's mild and it will go away. It goes away within a few weeks. That's not a big deal. Okay. More than mild, or it doesn't go away, then let's have a discussion. But a little nipple sensitivity is not a huge deal, but many men will get really freaked out about that because they've read horror stories, or they think that they're gonna wake up the next day with a boob. So I am fully aware that I have a lot rosier view of TRT than maybe the mainstream conventional clinician. Now, I do think that I've got a strong argument for that viewpoint, and simply putting some letters behind your name, or the quick one that comes to mind is an endocrinologist who is obviously very bright and probably very great at what they do, or maybe most of what they do. Just because you have a certain degree does not necessarily mean everything you say is accurate or the gospel, and that's called the argument from authority. It's a not uncommon argument. It's where someone says, "Well, I've got this particular in this scenario, I've got this particular degree or certificate, and so that makes me the expert." Not discounting that is important and does mean a lot. All I'm saying is that I think, for the purpose of academia, if you will, I guess, an argument is made, and either it's a good argument or a bad argument, and that can definitely be had. Let's talk about it. So, if there's evidence to refute some of the things I've said, then by all means, let's hash it out. I reserve the right to say that I was wrong. I try to dig in and really learn both sides and understand the concepts. So, it's either a good argument or a bad argument. It's not going to be as simple as me saying to maybe a peer or a staff member, well, I am the family nurse practitioner, so I'm correct. No, let's bring evidence to support what we're saying. I do tend to have a rosier view. I think again, 95% of the time, I think the benefits are going to far outweigh the risks. One thing I didn't mention that I need to is one of the risks or things to weigh out when considering to treat or not to treat. To maintain the benefit of the testosterone therapy, and this is very important, you have to maintain the therapy. You have to maintain the medication. So it is and it can be a long-term therapy. It's not something that you do for 6 months and you're all better, you stop and everything stays the same. Some are already very aware of that concept. Some patients need to be reminded. Everyone should be told that. Regardless, it is a long-term therapy. If you get benefit from the therapy, to maintain that benefit, you're going to maintain those levels and the medication that's giving you those levels. So, it's important to weigh that out for when you're kind of having a dialogue, a discussion with the person. And when you're thinking about it, okay, if it's topical, okay, I'm going to need to put this on daily, and in some cases twice a day, depending upon how the person likes to do it, how the clinician likes to dose it, or what's maybe needed based upon response. So I'm going to have to do this daily, or if it's an injection, I'm going to need to take this injection weekly for potentially forever. Okay, so it is a maintenance therapy, a regimen. No different than if someone has a thyroid deficiency, they're hypothyroid. They take thyroid medication forever, the rest of their life. So very similar. So that does need to be weighed out, especially for the guy that's maybe very mild. His symptoms are very mild. Maybe his testosterone levels are not horribly low. Maybe they're borderline low. Is that something he really wants to take on right now? Or does he wait another few years before he really, digs into something that's if the person wants to maintain their benefits, that is going to be a long-term therapy. So things to think about, things to weigh out. Again, most of the time, I think it's pretty straightforward as far as benefits versus risks. But I hope I've given fairly thorough kind of swim through my head, which could be scary. It could be a dangerous swim. About things to think about, things to consider when to treat or not to treat the person with testosterone. Thanks.